Okay, I think we should have a start now, and essentially we will be talking about well, tonight's or today's lecture will be designated for lipidology. Welcome again to our monthly round, and I will start today's lecture with a case vignette, and from there I will take you through the literature and updates. The objective of today's lecture is to take you through some of the basics of lipidology, and from there we expand to, or cast the net further out to go through the advances in our knowledge about lipidology. فما راح أتكلم كثير بالعلاجات والأمور اللي تخص العلاجات والadvances we have in treatment بهذه المحاضرة. ممكن بمحاضرة قادمة نسوي هذا الشيء، ولكن كان هناك advances in our knowledge فيما يخص الليبيدز، وهذا الشيء حقيقة إلا طبعا repercussions وإلى تبعات على العلاج والأمور اللي نستخدمها بالعلاج وما إلى ذلك. وكل هاي الأدوية اللي راح تشوفوها تجي بالمستقبل هي الحقيقة stemmed out of the advances in our knowledge فيما يخص novel pathways, molecular pathways related to dyslipidemia. هذا المصطلح العام اللي احنا بنستخدمه واللي يفتقد إلى الدقة الحقيقة. Anyway, if I can go ahead with the first case of a 29-year-old male of a Sri Lankan background who has actually a fairly dramatic presentation to the emergency department. He was previously healthy on no medications, a non-smoker, no alcohol drinker, who presented with acute onset of abdominal pain, nausea and vomiting في حوالي الساعة 7 الصبح, and with about 12-hour history of the symptom that progressed very rapidly overnight. He was tachypnic, tachycardic when he first presented. He did have some degree of peritonitis limited to the epigastrium, and he was overweight. He was on his venous blood gas in the emergency department. He was noted to be acidotic with low carb, high potassium, and low calcium. His basic biochem was sent to the laboratory, but showed, as you could see here, normal kidney function, normal slightly elevated white blood cell count, and normal LFTs. However, his lipase came back at 3,000, so that was screamingly high levels. Triglyceride was just as high. So normally triglyceride is up to 2 millimole per liter, and his was close to 100. Okay, so the diagnosis was almost made on the spot. This is a case of pancreatitis related to hypertriglyceridemia. في كل حالة البنكرياتايتس you would expect the triglyceride to go up. فهذا قد ملاحظة شوية نخليها في بالنا، ولكن ما تصعد ل 99 حقيقة، ما تعبر ال 10. And if it cross some cases report it goes up to 20, very unusual. ولكن definitely not above 20 millimole per liter. So again, this case of trig-induced pancreatitis, again, the diagnosis was made within a few hours of admission. So there was no diagnostic dilemma in this case. However, within a few hours, by 4 o'clock in the afternoon, the patient's GCS started to drop down. He became, again, tachypnic, required paragraph oxygen to maintain his saturation with the tachypnea with a respiratory rate of 30. He was immediately commenced on dextrose insulin infusion. However, his pH remained acidotic and with a low carb and high potassium. His triglycerides shortly after commencing the IV insulin dextrose infusion dropped down modestly down to 77. So that's a fairly modest drop, almost doesn't help much. they discussed with us, and we decided to go ahead with plasmapheresis, knowing that the plasmapheresis is probably the most effective acute or immediate intervention in this case. So Dr. Ali Hamza يوضح إنه 99 millimole equivalent to almost 4,000 milligram per deciliter. شكرا دكتور علي. حوالي الساعة 6 مساء the patient was transferred to the hospital where the plasmapheresis was initiated. لاحظوا هنا إنه إحنا دائما نذكر الوقت بالساعات لأنه for medical legality you have to document the time, see exactly what you've done in each time point. وهذا إلى مهم فيما لو حصل تحقيق بالموضوع. إيش قد يتأخر المريض على البلازمافيريسيس؟ هل هناك إشكال بالنقل إلى آخره. Anyway, so things got, he was still acidotic with bicarb of 29 and pH 6.8 when we started the plasmapheresis. He required ICU admission طبعا, required inotropes. The plasmapheresis started الحقيقة at 8 p.m. المريض وصل 6 p.m. to the tertiary hospital. بعدها بساعتين we started the plasmapheresis with a calcium replacement. However, his fibrinogen dropped down as we expect, as we always see, or not always, fairly commonly see with plasmapheresis. And he did have continuous renal replacement therapy for that during that admission. So on the 7th, in about 3 days' time, the lactate had gone up, the abdominal rigidity after it eased off, it actually got worse. And his clinical picture deteriorated again. So the surgeon, which he was admitted under, opted to do a laparotomy, and they found quite a bit of blood-stained serous fluid, which was drained. And when they drained the fluid from the abdomen, there was a good decompression of the viscera, and they left a vac dressing on the open wound. 3 days after the laparotomy, while the surgeon was inspecting his vac, they noticed that the bowel looked necrotic, so they took him back to theater. أخذوه مرة ثانية للثياتر, and he was found to have necrosis of the transverse colon, and he underwent subsequently hemicolectomy. He did have, unsurprisingly, reactive pleural effusion, which was drained. He also, the plasmapheresis للأسف was complicated with right femoral vein DVT, and we have to employ an IVC filter an IVC filter to prevent that clot, which is in the proximal DVT, we call it, as opposed to distal, which has a very high likelihood of migrating to the pulmonary vein and end up with a PE. So that was another challenge we have to face with this guy. Later on, we did a CT of the abdomen a few days later that showed the necrosis of the pancreas, which we decided to treat conservatively. And following images noted for, again, severe necrotizing pancreatitis with a lot of collection. He was, during this time, he was on parenteral feed, and it took us 3 weeks of admission to get to it's almost a month worth of admission before commencing oral feed again. And he was discharged to the ward after 3 weeks, and from there he went home. So this guy has complicated necrotizing pancreatitis with severe hypocalcemia, ischemic bowel, and DVT. But he made it. He did survive. يعني حقيقة, this presentation tends to have very high mortality rate. Now, this is a chart that I would like to show you here, and just to show you when we first, this is the triglyceride level when he first arrived, close to 4,000 milligram per deciliter. Now, when we started the insulin infusion, it dropped down to 77 or thereabout. When we started the plasma exchange, it dropped down all the way to under 10 after the first session of plasma exchange, just to show you how effective plasma exchange in lowering triglycerides. Okay, so I'll stop here, and I'll take your question in relation to the case. إذا أحد عنده سؤال يخص الحالة its progress before we move on to the lipids and the management. It's quite interesting. واحد got DVT use. Well, شكرا دكتور علي، لأنه دكتور علي يسأل يقول إذا ليش ما استخدمنا ثيرابيوتيك كليكسين أو ثيرابيوتيك دوز. بالحقيقة لأنه هذول عندهم high risk of hemorrhagic pancreatitis. They can bleed profoundly to the pancreas, so we opted to avoid it. And they can always have even disseminated intravascular coagulation, particularly with reduced fibrinogen. So طبعا الهيماتولوجيست كان معنا على طول الخط with their advices. Any other question in relation to the case طبعا? Well, دكتور أحمد نصار, من فضلكم خلي الأسئلة تكون للجميع، سواء الجميع كان ممكن يقرأها، وأشكركم يعني إنه تخصوني بالأسئلة، بس خلي الجميع يشارك بهذه. Now the answer is in relation to السؤال يقول ليش شو وقت نستخدم when do we start anti-lipids or oral anti-lipids? When the day the person started to take or to tolerate oral intake, that's when you give them. And the fenofibrate, I can assure you, is a fairly effective drug in bringing triglyceride from 100, 200, whatever you can measure, down to next to zero. It's fairly effective medication once the patient can tolerate it. Why we use rosuvastatin plus fenofibrate? It's a good question, because the pathway of triglyceride synthesis and consumption is different than the cholesterol, generally speaking. However, the triglyceride is part of the LDL, VLDL, as you know, اللي حبينا بالمحاضرة. ولها السبب you see some 10 to 15% drop in the triglyceride with the statin. Okay, so you cover that bit as well. نعم دكتورة نور، السؤال هو البلازما exchange differ from the from the usual the answer is yes, we use a different filter, and we use albumin in specific for the triglyceride plasma exchange. وهي guidelines تأكد عليها طبعا for a good reason. So yeah, albumin is your solute that you use, and you do use a special filter for it. Any more questions شباب؟ ولا انتقل للتفاصيل؟ Okay, good. Okay, so that was some good questions there. We'll move on now to the طبعا it's quite interesting إنه شلون تغطي الكيس هذه not even 10 minutes 15 minutes run through ولهسه احنا نسميها كيس فينيت. لكن هذا كان حقيقة المريض one of the flagged challenging cases in the ward. Okay, يعني كل يوم كان هناك شيء، كل يوم اكو اكثر من حادثة تخص المريض. He had 3 med calls at some stage. A medical emergency team required in one day. So يعني he's a young man, medical يعني students وما أعرف إيش healthy otherwise, and all of a sudden he was in ICU fighting for his life. يعني you could see him well in the morning round, in the evening round you see him completely gone through dramatic events. And just to show everyone how unpredictable the course of pancreatitis and complicated can be. على كل حال, I'll move on to lipids now. Lipids is a pro-atherosclerosis, well, we know that, but it's a pro-hormones. And lipids is our energy reservoir. Now, why would we, well, in today's talk, I'll be discussing cholesterol, triglyceride and free fatty acids, lipoproteins, we'll go through them, and we'll go through apolipoproteins. Now, أنا apolipoproteins as well. أنا الحقيقة كنت يعني أفكر إن شلون أسوي المحاضرة بهالتعقيد، بموضوع معقد جدا، هذا ما ينطي محاضرة واحدة، ولكن الهدف منه هو توضيح مثل ما قلت في البداية، نوضح البيسز ونوضح الادفانسز in our knowledge بطريقة تكون سلسة، ما تكون مملة، يعني ومناسبة لعملكم أيضا، وأتمنى تكون يعني أكون تقدير. I look forward for your feedback anyway. All right, cholesterol. Why is it an endocrine substance? Cholesterol مثل ما تعرفون is a carbon compound, fairly long carbon compound, and it has a steroid or sterol component. The synthesis of which is primarily in the liver, where the acetyl-CoA undergo catalyzed by the HMG-CoA synthase. It gets converted into through a fairly complex pathway in the cell cytoplasm, endoplasmic reticulum, وكل هذه organelles be involved until you get a mevalonic acid, and the mevalonate will be subsequently phosphorylated and end up in a fairly complex 19 or more than 19 conversion steps into the cholesterol part. Now, هذا كله طبعا the statin works on this particular part and blocks the synthase, and by doing so it blocks the cholesterol synthesis. ولكن this is not the primary way or the principal way where the statin reduces the cholesterol. اللي يحصل إنه we look at lowering the LDL, the bad cholesterol, اللي راح أتكلم عنه بعد شوي. Now, when the cell is deprived of cholesterol, when the level of intracellular level of cholesterol drops down بفعل الستاتين, as a compensatory mechanism, the cell will promotes synthesis of LDL receptors. بهالطريقة, it will try to capture more cholesterol-rich lipoprotein اللي هو LDL. فبطريقة غير مباشرة ال LDL يقل بالستاتين، مو بطريقة مباشرة. وهذه مهمة لأنه it doesn't help with the lipoprotein little a, وراح نتكلم عنه, and it doesn't help with that much with the triglyceride. ال LDL بشوية triglyceride، فمن تستهلكه تقل الترايغليسيرايد بشكل بسيط. لها سبب نعطي جواب على سؤال السائل. لها سبب نعطي ستاتين ويا الفينوفايبريت. يعني always with mild high triglyceride تبدي بالستاتين قبل لا تبدي بالفينوفايبريت. لها سبب لأنه ال LDL receptor compensatory mechanism will eventually lead to reduction in LDL subsequent to the triglyceride to a modest, very modest and humble degree. Now, again, why would we be interested? Why would the endocrinologist be talking about the cholesterol? لأنه the sterol component of the cholesterol is will become later on to the part of the any steroid-based hormone, progesterone, aldosterone, cortisol, testosterone, estradiol, estrogen. فكل هذه هرمونات أخرى كثيرة تأخذ الستركتشر مالتها من الستيرول component of the cholesterol. لهالسبب احنا دائما نقول مع الكارديولوجيست زملائنا الكارديولوجيست وبقية الاختصاصات نقول الكوليسترول is our problem first. اوكي طبعا هذا كله في جانب، وفي جانب آخر لا ننسى أن هناك شيء مهم جدا يبني الكوليسترول اللي هو فيتامين دي. اوكي so قبل لا ابدي كان عندي اخر سلايد اخر اكمله عن الكوليسترول اذا اكو شيء قبل لا ابدي البولز ايضا. اوكي alright نتوقف هنا وراح ابدي البولز لان الحقيقه مهم اعرف البيس لاين understanding of the case before نبدي ندخل بالتفاصيل المهمه. Alright, so the first question of the poll is يخص lipoprotein. So the lower the density of the lipoprotein, the richer the cholesterol will be. True or false? هذا السؤال الأول. كل ما تقل الدنسيتي مع اللايبوبروتين معناها الكوليسترول باللايبوبروتين أكثر. Okay, I'll have to stop the poll and I will share the result with you حتى تعرفون ايش قد الإجابة. 80% يعني 8 من أصل و10 من أصل 12 قالوا true and the other two said it's false. Okay, we'll leave it. Go back to the next question. For a given percentage of weight loss, the drop in LDL is expected to be proportional to the baseline BMI. بعبارة أخرى حتى بسط السؤال. For a given weight loss, لنفترض أن الweight loss هو 20%. The expected drop in the LDL with that weight loss is proportional to the baseline BMI. بعبارة كل ما تكون ال BMI أعلى كل ما يكون ال LDL drop أكثر بتخفيض الوزن. True or false? سؤال شوية صعب tricky but you can make it. All right, I'll stop the poll now and share the result. And most of you, the answers were no. And okay, I'll leave it as such, and we'll go through the lecture, and that should answer those two questions. All right. triglyceride. Now احنا تكلمنا عن الكوليسترول بشكل عام، تكلمنا كيف يصنع، ليش هو يعتبر an endocrine substrate أو pro-hormone substrate because of the sterol component. and وضحنا إنه ملاحظة مهمة هو إنه when you block the cholesterol intracellular cholesterol synthesis, then the LDL receptor on the cell number will increase, and by doing so, as a compensatory mechanism, and by doing so, the LDL will drop down. Okay, let's move on to triglyceride. Now, triglyceride is a combination of glycerol and 3 fatty acids. Okay. The glucose, when it enters the mitochondria, they get through the pyruvate cycle, you will end up with a byproduct called glycerol. You take one molecule plus 3 fatty acids, you end up with triglyceride. Now, بسيط ماكو حاجه نفوت بتفصيل اكثر، لكن الفكره انه الجليسرول زائد fatty acid you get triglyceride. Triglyceride, on the other hand, when it's subject to lipolysis with lipoprotein lipase, الانزيم اللي قسناه بهذا المريض وكان بال 3000, you will end up with fatty acids. So there is an equilibrium between triglyceride and free fatty acids. Now هذا so often full screen. Okay, sorry. Now الحقيقة هذا الموضوع مهم بهذه النقطة بالذات. Now, why do we need triglyceride? Why would we need fatty acids? The reason being, the glucose has only 6 carbon atoms. The fatty acid has a lot more longer carbon atoms. As an energy storage, glucose is a fairly poor substance to store, ineffective substance to store. غير فعالة بالخزن. الأفضل you need to have more carbon atom بعبارة إنه it'll become more effective in terms of energy storage. And that's why we need fatty acids as an effective substance or energy substrate for storage. And this is the cycle that I'm referring to. Glucose get converted to triglyceride. A triglyceride get converted to free fatty acids, and these will be stored in the blood, in the body as adipose tissue, as fat. So fat is our glucose reservoir. كل ما تقل عندنا calorie intake, you will have to burn fat to get more glucose for your survival. From there, I move on to the types of fatty acids we have. Saturated, when all the carbon atoms is hydroxylated. Mono, when you have only one double bond there, and when you have more than double bonds and a few hydrocarbon atom that's not fully bonded to hydrogen atoms, that's where you get the polyunsaturated fat. And each class of these fatty acids has a different biophysical role. احنا دائما نشجع على اساس انه البولي انساتوريتد هي افضل. الى حد ما هذا الكلام صحيح. الساتوريتد فات الحقيقه هي unhealthy. Well, we know that the unsaturated fat, some of them can be healthy and some of them are pro-inflammatory. على سبيل المثال omega 6 و omega 3. Omega 3 is a polyunsaturated while omega 6 is not. Well, still unsaturated, but it's not polyunsaturated. So omega 3 اللي تلاقيه بالفيش oil it's anti-inflammatory, while omega 6 اللي تلاقيه بالplant oil على سبيل المثال، هذا دهون المواد النباتية، الزيوت النباتية عدا الأوليف أويل. بقية الزيوت النباتية الحقيقة هي عندها بها omega 6, and omega 6 is actually pro-inflammatory. It promotes prostaglandin. ولو هذه contention بها جدل، لكن عموما إنه we don't prefer omega 6 and hence we don't promote vegetable oils. We shouldn't really. I will get back to this slide later because I think there's something more important to talk about, and that is lipoproteins. Now, lipoprotein, why do we need them? Because cholesterol is a hydrophobic. It needs something to, it needs to be compounded with a triglyceride in order for it to be mobilized from the liver to different organs through the blood. هذه مهمة. فالترايغليسيرايد الآن أصبح لها دور ثاني. هناك جانبين لهذا الموضوع. الجانب الأول إنه triglyceride through its equilibrium with the fatty acids, it acts as an energy substrate. That's one. Two, with the triglyceride being packaged with the cholesterol, you can then move the cholesterol from the liver to different organs, لأن الكوليسترول is essential في صناعة الهرمونات وفي صناعة في brain development, neurocyte survival, plasma membrane إلى آخره، كلها تحتاج pure cholesterol particles. بالإضافة إلى موضوع الانرجي والسبستريت، الكوليسترول is a prerequisite for our survival, for our cell to function properly. Okay. ولهالسبب من يقل الكوليسترول داخل السيل راح السيل try to compensate by increasing the number of LDL receptors. Now, the apolipoproteins are just hinges. They're just scavengers. What they do they work as a hook to hook themselves, to hook the lipoprotein to the cell membrane receptors حتى تقدر الخلية تستهلك. أن اللي يحصل الآن كل ما أجاوب على السؤال الأول، كل ما تزيد الترايغليسرايد concentration in the lipoprotein. Okay, so the lipoprotein is a combination of triglyceride and cholesterol. Okay, it serves two purposes. It delivers the cholesterol to the cell and it delivers the triglyceride into the cell in form of fatty acids. Now, كل ما يزيد triglyceride concentration كل ما الدنسيتي مع lipoprotein تقل. بعبارة أخرى ال VLDL, very low density lipoprotein, has a much higher triglyceride, much lower cholesterol component. The intermediate IDL, intermediate density lipoprotein, has a little bit lower triglyceride, a little bit higher cholesterol component, concentration or mixture. An LDL has a even lower triglyceride and a higher cholesterol, and that's why the LDL is the bad cholesterol, is the most atherogenic. Okay? Now, so باختصار, you have the triglyceride, you have the cholesterol esters in the lipoprotein, and you have the apolipoprotein, which is predominantly ApoB100. Yeah? Now, its main role to transport the cholesterol and, of course, the triglyceride, as mentioned. So this is your first answer. The bigger the particles means the higher concentration of the triglyceride, and therefore the lower the density of the particle, chylomicron being the lowest density, the least density, and it goes downward as you move along the spectrum of triglyceride versus cholesterol concentration. Okay, so this is one important part that we need to clarify. Moving along, again, so the density of the lipoprotein is dictated by the triglyceride concentration. Now, cells consumption. It is important for us to know that كل ما ينتقل اللايبوبروتين في الدم، كل خلية تبدي تاخذ شوية من triglyceride محتاجة بالدرجة الأساس محتاجة energy. Triglyceride will then be broken down through lipoprotein lipase into free fatty acids. So that's your energy substrate. الشيء المهم اللي أتمنى نتفق عليه يعني establish with you today is the VLDL, the principal lipoprotein in the upstream lipoprotein cascades. The VLDL الحقيقة is synthesized in the hepatocyte de novo. وبهالسبب الحقيقة من الخطأ نقول للمريض إنه أنت من تنزل وزنك الكوليسترول مالتك راح يقل بشكل ملحوظ. هذا كلام غير علمي وغير صحيح. Now, liposynthesis, and this slide will further clarify this particular point, and that is the liposynthesis. It has an extrinsic pathway. This is the pathway when the food comes, well, when the lipoproteins, or particularly the chylomicrons, comes through the food. This is a very high rich in triglyceride and low cholesterol, and they get transported to the liver and is subject to further changes into VLDL, IDL, and LDL as well. إلى آخره. Now, the intrinsic pathway relies primarily on the de novo synthesis of the triglyceride from glucose, as mentioned, and from the free fatty acids. What we need to know is that the extrinsic pathway اللي يجي بالأكل هو 20%, the intrinsic pathway هو 80%. Now, إذا تشوفون هذا الأكاديميك، خلينا نحكي شوية clinical, okay? Clinical academics, that's our theme. اللي عفوا اللي يحصل انه من في الدراسات اللي سووها من with the percentage of drop in LDL with dieting, with severe dieting doesn't go below. أنا ما أتكلم الآن عن high fat low carb diet, just low carb diet without high fat, okay? The drop in the LDL was always under 1 millimole per liter. لأنه ال LDL اللي يجي من الكايلومايكرونز اللي تجي عن طريق الأكل 20%. فإذا كان عندك المريض البيس لاين مالته LDL عالي كأن يكون 5 and you want to bring it down to 2, المريض حيقول لك والله حأغير أكلي وأنزل وزني وما أعرف إيش حتى يقلل ال LDL. وأنت تقول له okay, well go ahead, do that. It's good to do it anyway, but you have to bear in mind your LDL will drop down by 1 millimole per liter. Yours was 5, 20% of 5 is 1, and that's the expected drop in your LDL. You won't get more than that. The LDL is predominantly synthesized de novo, and that's dictated by your genetics. I mean, bad luck if you have the bad genes that promotes the ApoB synthesis or triglyceride, and there's loads and loads of genetic mutation which we cannot cover in tonight's or today's talk in any way or form. And it just shows you that there's not only the triglyceride, or there's some enzymes, ApoC and ApoB, and these apoproteins genetics mutations, how they impact the level of the bad cholesterols in general, irrespective of the patient weight, dietary habits, their lifestyle. Okay, so it's all primarily in the genes. Well, at least 80% of it. Okay, now اللي أريدكم أن touch base إنه ال LDL اللي أصور هاي تعرفوها كلها المفروض تعرفوها، إحنا كنا نعرف هذا عن إنه ال LDL that you get reported, it's not measured. The LDL can be only measured in tandem mass spectrometry. So we use the Fred-Wald formula to calculate the LDL, which equals to the total cholesterol minus HDL minus triglyceride. And therefore, if you have very high triglyceride, you might end up with underestimate the LDL, لأن الtriglyceride عندك عالية. So you know, في كثير من الأحيان من triglyceride تكون above 20, the laboratory refuses to, and quite rightly so, refuses to report or decline to report the LDL because the formula will tell you that the LDL is actually going to be good, but it's not good. This is a simple example that shows how the low or high HDL, low triglyceride can give you false reassuring LDL, where the actual LDL was for this patient on tandem mass was much higher. Now, a question I've mentioned in the, I've got the second questions in the polls, and it shows that actually the leaner the person, the more likely they lose, the more robust the drop in the LDL will be for a given weight loss. بعبارة أخرى، احنا نعرف انه الاديبوز تشوي ريزرفوار فور فري فاتي اسيدز، واللي من عنده يصير ترايجليسرايد، من ترايجليسرايد راح يصير عندك ال LDL بالنهاية. فمن عندك high reservoir بالmorbidly obese patient, they will compensate for the weight loss. Still, they will not get affected. You do have a decent reservoir that could tolerate the 10 and 15% drop in the weight. لكن من يكون عندك الريزرفوار قليل، أي weight loss will show a major impact. بعبارة أخرى إنه من يجيك المريض والبي ام اي مالته 26 مثلا، with weight loss you would expect better drop, a more drop in the LDL than the the same person, if he or she had a BMI of 40, for example. أنا ما أتكلم الآن عن weight loss in kilograms، أنا بتكلم عن percentage. نتكلم 10%. شخص كان BMI مالته 30, 10% of their 30 dropped down to 27. Another person, the BMI was 40, 10% dropped down to 36. لكن ال LDL for a 10% drop in the BMI person of 30 was a much more drop than those who with the BMI of 40. Okay, شباب فخلي هذه تكون واضحة. Now, فيما يخص diabetes and the lipoproteins, I think we should all know now. We should all know by now that the LDL particles tend to be thinner and denser, more particles for a given volume of blood, for a given measured or calculated. مو بس هو calculated, even measured tandem mass. حتى من يقيسون الآن في بالريسيرش بيقيسون number of particles مو أو إحنا نسميه density. How many particles per mil or per micromole. فبغض النظر عن وزن ال LDL اللي عندك، الوزن ايش قد particles موجوده، كل ما يكون عدد البارتيكلز اكثر كل ما تكون الاثيروجينيسيتي اكثر. So that's one thing. احنا نعرف كل زين انه باللايبوبروتين لايبيز بالدايابيتيز بالميتابوليك سيندروم يكون بالانسولين ريزيستنس اللايبوبروتين لايبيز اكتيفيتي تقل، ومن تقل اللايبو اكتيفيتي الفي ال دي ال راح يزيد، للترايجليسيرايد راح يزيد لانه انت محتاج اللايبيز حتى يحول الترايجليسيرايد into free fatty acids. Yeah. فبهالطريقه this is the usual. ومن يكون عندك ال VLDL particles عالي ال HDL راح يقل، وراح نتكلم عن reverse pathway in a second. بعباره اخرى, so this is the usual profile of the metabolic syndrome. Lipoprotein insulin resistance يزيد, lipoprotein activity lipase activity تقل, the triglyceride وال VLDL يصعد, ال HDL يقل. Okay. Now, the HDL, the reverse pathway. HDL, the حقيقة, is a very fascinating molecule, and it gets synthesized in the periphery, macrophages, endothelial tissues, and it gets synthesized in a fairly complex using the AB cassette system. And what it does, through the cholesterol esterol transferase enzyme, it exchanges. Its main role is to take the cholesterol back from the cell to the liver, often from the cells. The cholesterol وصل للcells, okay? The intracellular concentration of the cholesterol, it might have gone up, okay? And with the HDL, فتبدأ الخلية تصنع ال HDL, مو الليفر يصنعها, بقية الخلايا. يأخذ الكوليسترول يرجع للليفر to transport it back to the liver with a view to be excreted in the bile and get rid of it. فبالطريقة فهي الحقيقة it's a reverse transport pathway. And this efflux of the cholesterol esters, it's meant to be atherogenic, and during this process, the HDL, by definition, under high cholesterol, low triglyceride, can take something from the IDL. So there's a bit of exchange and on its way to the liver to get rid of the cholesterol. So this is the presumed mechanism, protective mechanism the HDL can provide us, generally speaking, بشكل عام. ولكن عندنا مشكلة. بدينا نعرف, احنا قلنا نتكلم عن updates in our knowledge. إنه ال HDL now ما يجي it's not, there's HDL concentration and there's HDL molecules. And these molecules vary in size or particles, from small particle to medium to large, HDL 1, 2, 3. And even these HDLs, and this is dictated by the HDL 2 and 3 by the molecular weight, and it's different than the number. And even within the weight, they start to subclassify 3 into 3A, 3B, 3C, depends on the moiety and the electricity of the particles, and how these cells affect the cholesterol efflux from how these often molecules will affect the cholesterol efflux from the cell back to the liver. Each one works in a different efficacy. لهالسبب الترايل اللي يسوون الترايل على النياسين وغير النياسين ويشوفون انه الناس نزل التوتال HDL لكن ما كان اي cardiovascular protection. The trial was neutral. ما طلعت بنتائج ايجابيه. Of course it doesn't come with a neutral لانه it doesn't address these it looks at the HDL as a concentration. لكن احنا عندنا particles وهذه particles بيها numbers بيها size بيها density. And it seems to be, we don't know, we don't know for sure that perhaps the more dense the particle, the more efficient the cholesterol efflux can be. Perhaps, that could be wrong. ما متأكدين عن ده. وكل ما يكون ال cholesterol efflux pathway is more efficient, the more likely you're going to end up with a cardiovascular protection. That's the whole idea. This is a study done here that shows that the HDL concentration, unadjusted for the particle numbers, it showed a negative result. But when they adjusted for the particle numbers, the median with the confidence interval started to go to the unity line. So at least from negative to a neutral result. أكو كان تحسن بالنتائج بمجرد ما حسبوا ال concentrations مال HDL مو عفوا ال particles مو بس ال concentration. Okay, this is just to show you how complex the process is. واحنا نقعد نقول للمريض والله الHDL عندك الHDL عندك عالي، انت لا تخاف امورك زينه. هذا كلام حقيقه يفتقد الى علميا الان مرفوض. Okay. So in terms of academic, it's an antioxidant. It promotes HDL. It promotes cholesterol efflux from the macrophages all the way to the back to the liver. The denser the particle, the better. ممكن. ما متأكدين إنه عنده. HDL subtype 2 is now we think it's actually the bad cholesterol. We think ما متأكدين. HDL is an inverse predictor of cardiovascular. احنا نقول للمريض إنه هذا شيء جيد عندك ال HDL، لكن هذه very crude statement تفتقد إلى الدقة. Now I will talk later on about the ApoA. So this is academic. In terms of the clinical, I don't treat to increase the HDL level, but if the HDL levels were low, then I tend to treat the LDL more aggressively. Okay, weight loss does not improve HDL. خلينا نكون واضحين. يجيك المريض عنده ال HDL قليل يقول له ينزل وزنك، هذا كلام غير خطأ وما المفروض نقول للمريض. اوكي، المريض اللي يحب ينزل وزنه هذا موضوع آخر، لكن مو لا نتوقع انه ال HDL ممكن يقل. So, and by doing so, بعبارة أخرى إنه لا تتوقع إنه تخفيض الوزن يقلل ال HDL, and therefore it should not delay initiation of treatment. So this is the take-home messages that I'd like you to take from with regards to the HDL. Now, medical conditions specifically related to dyslipidemia, I thought I'll go through this. Hypothyroidism reduces the expression of LDL receptors. لهالسبب hypothyroidism is associated with increase in level of LDL. وإحنا قلناها تكلمنا فيما يخص subclinical hypothyroidism. One of the reasons what promoters to offer treatment is bad with a high elevated LDL. Again, estrogen in particular, it promotes synthesis of VLDL, and it has a very distinctive pattern where both the HDL and triglyceride goes up, and we don't like either of them. So in the hepatocyte promote triglyceride synthesis via the primarily utilizing the free fatty acids. So when we give someone estrogen-based contraceptive pills, we have to make sure that that triglyceride is not elevated, because you might increase it even further. Again, Cushing disease enhances hepatocyte synthesis of VLDL. Now, obesity, it increases adipocyte mass and therefore mobilization of free fatty acid, and therefore increased resistance, often insulin resistance, mediates high triglyceride. High carbohydrate intake by itself in obese patients, in particular, promotes VLDL synthesis. So this is a quick run through of some of the common conditions. I should have mentioned that the testosterone supplement reduces HDL, but this is an inconsistent finding across papers, and it should not really يعني في أنا ذكر مريض ادينا له على androgen supplement والجي في اتصل بي قال لي الاتش دي ال drop down, he's known to have ischemic heart disease, shall I cut down the testosterone supplement? And the answer is no. We expect that, and the study has showed that the endogenous testosterone does not suppress the HDL. It's only the exogenous testosterone supplement that do so in a hypogonad person without, in the paper showed that without any significant adverse cardiovascular effect. So we don't know exactly how the testo reduces the HDL, and كنت حقيقة كان عندي سلايد لطيف لهالخصوص هذا، لكن ما صار مجال أخليه لمحاضرة اليوم. Moving along to comparison between lipid metabolism between type 2 and type 1 diabetes. Now, both of them will have low lipoprotein lipase activity. Like in type 2, because of the insulin resistance, the hepatic production of VLDL increases, while in type 1, there are more than pathway that promotes high triglyceride as a one of them is glucagon-mediated free fatty acid mobilization, واللي احنا نشوفها بالDKA. Now, so I'll moving from there to the plasma exchange as a one-start touch base. That these are the indication with when you do plasma exchange in pancreatitis, when you have drop in calcium, fibrinogen, a drop in fibrinogen. And so our patient has two of these, and that was enough for us to call it for plasma exchange. الحقيقة, the decision in our case for initiation of PE was not delayed, لأنه كان من أول blood sample venous gas, his ionized calcium was low. Now, I will move quickly to the next case of a 31-year-old gravida 1, 8-week pregnant with a history of recurrent pancreatitis related to high triglyceride. I've seen this case in 2000, I can't remember, 2011, 2012. حقيقة كانت صعبة لأنه المريضة كانت يعني she was pregnant already and she had recurrent triglycerides. So she was non-smoker. Baseline triglyceride before initiation of fenofibrate was 60. Like من جتنا كانت already stopped her fenofibrate. So I started her on a very low-fat diet, and please أخذوها إذا هذه الكلمة ملاحظة تحفظوها من المحاضرة. الرسالة إذا وصلت حقيقة تستاهل المحاضرة كلها. Very low-fat diet, it does drop your triglyceride quite a lot, significantly. So she will almost tell the patient no fat whatsoever. That will bring to drop her triglyceride to 12, and she was off fenofibrate, okay? Still high. خاصة من مريض يكون عنده recurrent pancreatitis, you really want to see the triglyceride to be under 2, well and truly. So I added triple fish oil, and the triglyceride dropped down to 5. We gave her insulin, 4 units with meal, again helped to drop. So she started to take insulin. She's not diabetic. That helped. And by the 13th week of gestation, the triglyceride, we started her بمجرد ما وصلت للsecond trimester. Now we can use the fenofibrate. And we did use medium chain triglyceride diet اللي هو naturopathy يصنعوه من الكوكوناتس. هذا يفيد حقيقة. It does help. Now there's a lot of reporting يقول لك إنه أنت شلون تأخذ triglyceride وحتى تقلل triglyceride. Well, medium chain triglyceride does reduce the total triglyceride. Although there's a controversial paper contradict these statements, but we use it. Now, moving from there to the apolipoprotein, the hinge proteins. These proteins' main role is to get the lipoprotein hooked up with the cell. Okay. Now we'll take you through each one of them very in a user-friendly way or in a presenter-friendly way. So حتى واحد يروج. ApoB protein, وهذا تقولون عنه ApoB 100 اللي synthesized by the liver, or ApoB 40 something synthesized by the intestine. Now the ApoB is the principal apoprotein in the whole lipoproteins, LDL, VLDL, كلها. Okay, so that's why in the cases of residual risk, NIH research, Peter Tocqueville and his group decided to measure the ApoB. ولاحظ ان الأبو بي يكون عالي، لكن هذه costly measure and you don't need it. Non-HDL is an effective method to tell you how much is the ApoB. Again, the ApoB 100 is a surrogate marker of all the bad lipoproteins, VL, IDL, and LDL, okay? The ApoA is a more fascinating molecule. So the ribbon here, هذا اللون الأحمر, it's a helical ويتغير مع شكل to adapt for the HDL molecule. It's the principal APO of the HDL, okay? ApoB is something that I want to focus on in these two slides. There's more than ApoB, E2 and 3 phenotypes, or genophenotypes. And ApoT is protective against cardiovascular, so it's a good thing. E2 is protective, E3 is neuroprotective, E2 is cardiovascular protective, E3 is neuroprotective, E4 is a pro-atherosclerotic. Because it competes with the LDL for the receptor, and therefore when you have a high E4, اللي راح يصير عندك ال LDL راح يصعد. And it can also increase the lipoprotein little a. This is a study done on the EPE. All these more or less recent studies, and just to show you, with each genophenotypes of the ApoE, 2, 3, 2, 4, 3, 3, 3, 4, and 4, 4, the more 4 you get, the more likely you have higher LPA and LD concentrations. Okay, مرة أخرى كل ما يكون عندك two alleles of the E4, the more likely you're going to have higher LDL, higher LP little a, for reasons that I just mentioned, competition with the LDL receptor. Now, there was a study that showed this. In this study, it showed that the risk of cardiovascular disease is about 40% higher when you have ApoE4 genotype, and the angiogram tend to show a disseminated coronary disease. والحقيقة هذا يعني some studies show the effect of ApoE is worse than smoking on the coronaries. I'll move on to my last section of the study of the talk, and that's of the round, and that's lipoprotein little a. It is atherogenic. In the past, we did not know if it was or was not atherogenic. What I can tell you now, we confirm through the study that the cardiovascular risk odds ratio goes in a longitudinal way, similar to the same cardiovascular ratio that you'll get to see with the LDL. The lipoprotein little a is a modulated LDL. This is how I need you to remember it. It does even compete with the LDL, but it's less effective in capturing. It shows less efficacy in capturing the LDL receptors. Okay. It also has a homology with the plasminogen, but it's less biologically active, and therefore acts as a physiological antagonist of the plasmin. Promoting thrombosis. One of the أحد الأسباب متى أفكر أني بالليبوبروتين little a, when you have residual risks, someone the LDL يعني واحد ال LDL مالته 2 بعدين يصير عنده heart attacks أو يصير عنده DVT. One of the things that I will check for when someone have unprovoked deep venous thrombosis, I check the lipoprotein little a. The prevalence of high lipoprotein little a, LP little a, is actually similar to that of the familial dyslipidemia, 1 in 250. 1 in 250 patients you see in your practice will have a raised LP little a, okay? Now, something I should mention is, when do you suspect the patient have LP little a? One of the commonest clinical scenarios in the تعطي المريض statin وقاعد تعطيك high intensity كريستور على سبيل المثال، وقاعد تعطي هاي دوز، بس ال LDL مدى يقل. هل بالبداية شوية المفروض you would expect 60% drop in the LDL once you use statin، لكن من كل دروب ال LDL قل، خلينا نقول من 4 المفروض ينزل حقيقة easily comes down to 2. Okay, لكنه not drop down to 3 and stayed at 3. You double the dose, triple the dose, you add ezetimibe and still the LDL sitting at 3. والمريض يأكد لك يقول لك I am taking my tablet on time, I'm adherent to my medication, I don't skip it. ولكن مع ذلك ال LDL مدى ينزل as you would expect by 60%. That's when you know the LDL, that patient has a lipoprotein little a elevated, because it has a molecular mimicry. المولكول مالتها مشابهة لل LDL. So the machine, when measure it, not calculated, when measure it will measure it as an LDL. Now, Lp(a) does not respond to statin. لها سبب يقال. ليش doesn't respond to statin؟ لأنه الطريقة اللي statin تنزل بها ال LDL هو عن طريق recycle of the rebound in the LDL receptors مثل ما شرحت. لكن ال Lp(a) doesn't have, it has a poor affinity to the LDL receptors. فحتى من LDL receptor ترتفع عددها يرتفع in compensation. The Lp(a) does not get caught by it. It has poor affinity. So the drop in Lp(a) is about 10 or 15%. So the practice point that I need to finish off with is that when you calculate the LDL does not respond to the statin hibinaha, then you suspect the Lp(a). It needs high level to be atherogenic, more than 100 milligram per deciliter. So it is less atherogenic than the LDL, but it's never مع ذلك هو atherogenic، لكن مو بنفس القوة. Now, it needs to be lowered substantially to get that benefit. لأنه less atherogenic, you need to drop it down much more than the more potent atherogenic substance, such as the LDL. It does have a lot of variation in intra-individual variability, so you do need to have more than one reading. يعني إذا كان عندك أنت باللابوراتوري إمكانية تقيس ال Lp(a) وتدز المريض الإمارات ما أعرف وين حتى يفحص وياه، لا تدزه على once determination، خليه ياخذ أكثر من fasting sample، يكون كله fasting، أكثر من sample حتى تعرف إنه عنده مرتفع ولا لا. Okay. Now, من تبدي تعالج خلي في بالك انه it has poor response. بنفس الوقت من تبدي تعالج وتريد تعرف انه ال Lp(a) قل ولا ما قل، لازم تاخذ اكثر من one sample حتى تتاكد انه فعلا قل. بعباره اخرى انه الاسج اللي عندنا لقياس ال Lp(a is reliable، لكن the production of this protein, of the short half-life protein, varies from one day to the other. So you need more than one sample. Now, again, the statin has no effect or hardly any effect on the ما أعرف الإيرور وين صار. Sorry. It does have hardly any effect on the lipoprotein little a. And another important thing is renal patient cannot excrete Lp(a). فلها سبب, that's another reason they don't respond that well. PCSK9 inhibitor هي نفس المشكلة, it has a very modest effect on the about 30%. ACE inhibitor, one study showed in someone who had the proteinuria, would you believe that the ACE inhibitor can help with Lp(a) through mechanism we don't know? So there are some simple measures. Tranexamic acid can help, nicotinic acid, but like under dreadful side effects. So I'm just trying to get my cursor because I think I lost it here. There you go. So that's my last slide for the talk. I should stop here and start sharing the take your questions. اللي أحد عنده سؤال ممكن يسأل verbally أو يسأل بالchat box. Yeah, so the triglyceride, Dr. Ali يسأل, it is atherogenic indirectly, yeah. And that's why in the trial we showed if someone has diabetes and high triglyceride, it can be harmful. In non-diabetic, it's not that harmful. You get either neutral result or inconsistent result. اللي أرجو من حضراتكم إن يكون الأسئلة by all means اللي يحب يسأل verbally, they're welcome to. HDL types can change from 1 to 3, or they synthesize separately from the start. That's a good question, actually. They do change, yeah. Yeah. It's a fairly complex synthetic issue. So the modulation, they can modulate from 2 to 3. All right. Okay, so شكرا دكتور أحمد. شوف, we started to use statin in the second trimester. Okay, we have started to use fenofibrate in the second trimester. And we don't use, Dr. Ali, a low dose in pregnancy. وأشكرك على الملاحظة المهمة. The 48 fenofibrate is almost homeopathic, okay? So it's almost subtherapeutic dose. So if you want to treat, you got to hit it hard. So yes, we do. Now, now fenofibrate is always safer than gemfibrozil in pregnancy or outside pregnancy. The catch is شوف اللي ابدا انا كنت اتوقع حتكون اسئله على البريجنسي. المشكله تعرفون ليش احد الاسباب الرئيسيه انه يصير ريكرنت بنكرياتايتس؟ واحد عنده ترايجليسرايد والله الكحوليك. بمجرد ما يصير عندك recurrent pancreatitis, they will have fibrotic changes in the canali of the pancreas, and they can have pancreatitis even with a triglyceride of 2 and 1. Okay, فهذه المريضة اللي يعني قدمتها الحقيقة يعني we were expecting her to have pancreatitis at any time لأنه الفايبروسيس اللي يصير بالأورفيس وبالكنالي مع البنكرياس is already there. فما يحتاج هواي ترايجليسرايد حتى ممكن يكون يعني ما له علاقة يعني بالترايجليسرايد بالنهاية الآن أصبحت easy to blame on. شايف شخص يرتكب أكثر من جريمة وكل ما تصير جريمة يجيبوه يقول هو هذا اللي عنده history قديم بهي هالجرائم يجيبوني هو ما مسوي شيء خلاص هو اللي حصل. فالhistopathological changes in the pancreas will beget more pancreatic change, inflammation. Yeah. So the synthesis of the HDL, I mean, we don't have really much to offer to promote its synthesis. اللي يحصل دكتور محمد انه شفت بالسلايد هذا انه بعض الHDL سأحاول اطلع على السلايد حتى اشوفها. I don't know where it's going. Yeah, I think this slide. You could see here on this slide that okay, the HDL on its way in the reverse transport pathway, on its way في طريقة إلى الكبد حتى يخلص من الكوليسترول, it can exchange with the LDL. It can exchange some cholesterol in exchange for triglyceride with the LDL. وبالتالي you will lose some HDL. And therefore, if you reduce the LDL, the HDL will be less consumed on this pathway. The side consumption, more direct consumption, الconsumption بالطريقة اللي صار يقل، فبهالطريقة يرتفع عندك ال HDL يعني. في اللي احنا نسويه الان حاليا، المريض عنده high triglyceride, I do start them on triple strength fish oil 2-3 times a day, high dose of fish oil. I tend to get them to lose some weight. I mean, it's good to lose weight before pregnancy, but the principal treatment is to abstain from fat. And we stop the fenofibrate on the day she gets pregnant. I don't stop it before that, okay? واجبي إنه my main challenge is to take the patient all the way to the second trimester. Once they get to the second trimester, I'll start the fenofibrate immediately, okay? So it's only the first 12 weeks that we will need to worry about. بعديها the fenofibrate will take over. So that's the only thing I could do for them. Yeah. It's actually, the glucose is part of the substrate for triglyceride synthesis, but it seems to be واحنا نعرف كل شيء انه high calorie diet مثل ما ذكرنا يصحي triglyceride في LDL والى اخره. ولكن the very low fat diet is the principal issue. I mean, the calorie intake in pregnancy, I don't think you need to compromise it that much. The insulin will promote lipoprotein lipase, and by doing so, you consume triglyceride. That's a question from Dr. Ali. And how can you tell? How would the insulin drop the triglyceride? And so this is the presumed mechanism. What the serum level of triglyceride to start treatment? It depends on your risk. So someone without diabetes, someone without a history of pancreatitis. So let's say a low-risk patient with a fasting triglyceride above 2 nanomole per liter, or a random triglyceride above 6, I start treatment. ما أعرف ايش قد يصير بالمليغرام ديسيليتر. Above 2 and above 6, above 2 fasting and above 6. And this is in the, حقيقة in the general population. We do tend to give fenofibrate مثل ما تعرفون حضراتكم for someone who had a normal triglyceride under 2, but has diabetic proliferative retinopathy على سبيل المثال. So it can serve as a مثل الستاتين. It has a collateral benefit. Now, شيء مهم بالستاتين حقيقة أنا ما ذكرته، وإذا كنا عندنا محاضرة بالمستقبل. دكتور حسين نعم، بكل تأكيد we do use omega-3 in pregnancy to decrease triglyceride. It does work، لكن لا تعول عليها الكثير. Its efficacy in lowering the trig is lower, is less than those you get with diet modification. The laboratory, the commercial lab we have, they calculate, do not measure the LDL, because you need tandem mass. You need tandem mass to measure it. The answer is yes. وهذا اللي سويناه بالمريضة. The question is, can you use the insulin in someone ما عنده pancreatitis, high triglyceride but not diabetic? وهاي المريضة أنا specifically خليت هاي الكيس، المريضة لأن هي ما كان diabetes، وطناها very small doses of insulin, 4 units with each meal، بحيث ما يصير عندها hypoglycemia. And it worked. Yeah, you can use it, but very cautiously. You don't want to induce hypoglycemia. So the standard dose is 4 units. يعني 4 units الحقيقة مو كلش جرعة قوية، خاصة من ياخذها المريض ويا الأكل. Can you double check if the immunoassay you use for the LDL, is it to measure or to calculate? لأن ما عندنا هذا الشيء. هو سوفت وير موجود بالانالايزر على كل حال. Yeah. Okay. LDL, we have a small, dense, and large particles. Does mean anything from Dr. Ali Yasal? The smaller the smaller, denser the particle, بمعنى more number of particles you will get per volume, the more atherogenic. The LDL particle is atherogenic. The more you have of these particles, the more disadvantaged the patient will be. So from the cardiovascular perspective. Now, I took you through today or tonight's talk through the, we moved from, we showed you how the complex lipoprotein system works in our body and how its role, the cholesterol gets into play, the apoprotein gets into play. أبو سي على سبيل المثال، يعني احنا دائما نذكر نقيس ال LDL ونشوف المريض عنده ischemic heart disease نروح على ال LDL. This is the only thing we look at. الأبو سي على سبيل المثال، يعني إذا صير الأبو سي is a coenzyme with lipoprotein lipase. إذا كان عندك genetic mutation بالأبو سي 2 تقلل lipoprotein lipase يصعد triglyceride. فيعني هناك numerous genetic mutation that can affect each part of the cascades. And I think the most important points I wanted to pass over today is that فيما يخص lipoprotein, lipoprotein little a, when do you suspect it? What can you do about it with the little we have? Now we're having more armamentarium, more repertoire in our medications. نقدر نستخدم الانتي-sense therapy seems to be very effective in lipoprotein little a. ولكن هناك أشياء بسيطة يعني ممكن تستخدمها. اللي قدمت الACE inhibitor ممكن تساعد effectively 30% reduction. هذه مو قليل. The point is المهم إنه أنت شو تفكر به. HDL لا تعول عليه هواية، إذا قليل وإذا كثير، إذا if it was high ولا if it was low. HDL is a fairly complex molecule. We don't measure it correctly as yet. We don't know exactly how it works. في سؤال عفوا total cholesterol minus HDL minus trig على 5 is valid all the time? No, when you have very high triglyceride, you will underestimate your LDL. فدائما when you عندك high triglyceride above 20, do not be reassured إنه هذا المريض ما يحتاج ستاتين. واحنا عموما في كل الترايجليسرايد hypertriglyceridemia we always initiate statin beside the fenofibrate. We don't give it alone for a lot of reasons that I just mentioned. Some of them I mentioned, but no. Okay, so I don't know how you saw this lecture today, guys, before I go. I don't have experience with the VASC keeper. That's one of the visual stuff. دكتور حسين ممكن تعطينا فكرة عن الفاس كيبر؟
عفوا، السلام عليكم استاذ.
عليكم السلام حسين، شلونك؟
يعني هو هذا ابروفد يعني تايب من الاوميجا حقيقه. هو ايكوسبين تينويك اسيد فد EPA هو مثيل استر، يعني كان decrease the triglyceride more than the conventional omega-3, frankly. Using the TG, and there is cardiovascular benefit in diabetic patient, and the LDL on the target, but the TG more than 150 milligram can also use as a cardiovascular outcome benefit. فاسيبا يعني حصل FDA approval قبل يعني سنتين تقريبا، بس ما شاف حقيقة بالعراق، ما موجود.
ما موجود عندنا either. احنا we're still using the triple strength fish oil.
Thank you, sir.
You're welcome. Thanks for your contribution. Thank you. All right. Well, look, I think we had. I hope you did not find this lecture boring. Okay. لأن الموضوع حقيقة معقد وبهواية basic biochemistry, well, biochem. بس أنا حاولت أخلي قدر المستطاع related to our clinical practice. And in principle, one of my main objectives in this lecture is to show the update we have in our translational medicine or basic science فيما يخص lipoproteins. يعني الأبو ما كنا نهتم به. HDL ما كنا يعني كنا معولين عليه أكثر من اللازم. Okay. فأصور the fact that أنا أكثر الأشياء اللي يعني شفتها مثيرة شكرا دكتور عمر، شفتها مثيرة يعني شو فرحت بمعرفتها من بروف سوليفان. قدم لنا مرة إنه كيف الcellular cells depletion of cholesterol can lead into compensatory mechanism of LDL receptors recycling. And that's just fascinating. It answers a lot of questions. lipoprotein little a ما كنا نمر عليه مر الكرام. أنا أذكر في أحد الكونغرسات اللي مرينا عليها يجي واحد من الستيت forgot his name يقول LPA little a is not atherogenic. وطبعا ردينا عليه وإلى آخره. ولكن الآن أصبح هذا واقع حاله. الانتي سنس ثيرابي يعني ما تكلمت عنه الآن ولا وصلت لل the new antisense with PCSK9 you will come on. The PCSK9 inhibitors إذا تسمعون عنها أنا أقول لكم من الآن راح تصبح شيء من الماضي. أوكي. يعني هي بعد ما أخذت حيز كبير، وحتى بعض الشركات بدأت تنسحب من الأسواق لأنه الانتي سنس every 6 months تعطيه أنت و exactly just effective وeffective أكثر على الليبوبروتين ليتولاي. زين، وتقريبا نفس الكلفة ومثلا غاليين. والآن في حبوب أخرى نستخدمها oral tablet that can bypass the HMG-CoA reductase pathway to block the cortisol that doesn't cause any myositis. So, the field is evolving, following our knowledge, and I think that's a very good thing in many ways. Well, okay, well, thank you all. I'm كنت شوية nervous، كنت قلق إنه هاي المحاضرة لأن بها كثير basic science حتكون شوية draining ومملة، لكن I hope you enjoyed it all, and I look forward to seeing you next month. Next month will be the start of our andrology lectures. So we will have a series of andrologies, hypogonadism, to prolactinomas. في بعض الزملاء طلبوا محاضرات على prolactinomas, and I think we'll take about either 4 or 6 lectures, so 4 to 6 months. We'll be dedicating the talks to andrology. I'll leave it as such, and أشكركم للحضور حقيقة، وإن شاء الله and see you on the first Friday of November, and that will be on well, you got it in the email and the text, on the 3rd of November, same time as now. Shukran to you all. Thank you. Assalamu.